Good morning, everyone, and welcome to a panel discussion on putting health at the center of COVID recovery, the role of NCDs. So, as the whole world is suffering from this pandemic, we are seeing that this is posing incredible strain on both our health systems as well as also heightening complications for those with NCDs. As though it poses a challenge, it also poses an incredible opportunity for health system strengthening as well as for prioritizing NCDs. So today we have a panel with incredible civil society leaders from India, the Philippines, and South Africa coming together to discuss how this pandemic has helped them heighten awareness for their priorities of NCDs, social inequities, and increased access. Uh, so I myself am based in North Carolina, where this conference is being hosted, but we have panelists from around the world sharing incredible experiences of what COVID-19 has done from their work. So our very first panelist is actually from South Africa. Russell Rensburg is the director of the Rural Health Advocacy Project, which advocates for access to quality health services for rural and underserved populations. Prior to this, he spent 6 years with United Nations AIDS technical support for Eastern and South Africa. His advocacy is currently centered on health as a human right that is instrumental in enabling people to optimize functioning and living. Russell, over to you.
Thank you, Ms. Shah, for the wonderful introduction. And let me start by just thanking everybody else for the opportunity for us to come onto this panel. My name is Russell Rensburg. I'm from the Rural Health Advocacy Organization project in South Africa, where we advocate for access to quality healthcare services for rural and underserved communities. Just a big content introduction. I've got a few slides, and I think I'll just give a general overview around introducing our project, what the context in South Africa is like, a bit of a conversation around COVID in South Africa, the role of NCDs on COVID case severity, and just some little pointers around some of the touch points that we think will be important both during the pandemic and as we build back better. So the Rural Health Advocacy Project we're a division of the WITS Health Consortium, which is a wholly owned subsidiary of the University of the Witwatersrand, which is a leading university here in South Africa. We were established in 2009 as a partnership between the Rural Doctors Association of South Africa, the University of Witwatersrand Center for Rural Health, and Section 27, which is a leading public interest law group in South Africa. Our vision is for rural communities to access quality and equitable healthcare. And our mission is more around promoting and protecting and realizing the right to rural healthcare by connecting practice, policy, and partners. Our theory of change, which is really sort of shapes our work, is for rural communities to realize their right to access equitable and quality healthcare with health policies that are rural proof, that allocate sufficient funding, and to ensure that there are sufficient caring and advocacy competent healthcare work in a functional healthcare system based on primary healthcare principles. Rural health improvements require what we believe an active community and healthcare worker voice and should be influenced by the broader rural and social determinants of health. The way we work around rural proofing as a policy advocacy group, we obviously work with various stakeholders. And given that the government is the primary provider of services to rural communities, our work is often focused on the national policy space where our national department is responsible for shaping that. So part of the framework that we present is sort of looking at the issue through performance plans, strategic reviews, and the like, and working with stakeholders and trying to understand how will this policy land in a rural context? How will a rural implementation context and socioeconomic status impact on the ability of the policy to be implemented effectively? And I think I've just laid out a couple of steps that we do, and I'm sure in the resource pack we can go through these slides a little bit more. Now, South Africa, I think our story, we can't talk about health or or developing in South Africa without talking about income inequality. South Africa is probably the largest, one of the most unequal societies in the world. And sadly, 25 years after the banning of apartheid as a policy, a lot of that inequality still manifests along racial lines. And as we know, health and economic status as a very direct causal link, with poorer communities or more, what we call more deprived communities, less likely to access or have the health literacy to seek the health care that they need. We've got a strong constitutional framework which guarantees everyone access to health under Section 27, which includes reproductive health and emergency health. Our health system is also largely defined by a response to communicable diseases. We have the largest HIV response in the world with over 4.5 million people currently on treatment, but well below the first or second 90 of the UNAIDS strategy to end HIV as a public health threat. I think to do that, we probably would need to get to around 6.3 million people, which is really a 30% increase in our current coverage. Tuberculosis, the sister of HIV, some would say, remains the leading cause of death. And I think we have similar access challenges, particularly on the first 90, which is diagnosing the cases. Diabetes incidence in South Africa has really been expanding or exploding, particularly type 2 diabetes. And modeled estimates have really put, currently there's a huge treatment gap, with only 30% of those people currently aware of their status on treatment. So we have a long way to go to really just addressing NCDs and diabetes in particular. Like our approach is really mirrored around three different main policy levers. One of them is health financing. Currently we have quite comprehensive free public services that are nationally funded from nationally generated revenue, which means taxes. We have 9 different provinces, each who have their own provincial departments of health, and the funding is flowed through to or devolved down to these provinces based on the formula that's largely informed by existing healthcare utilization. Our current resource allocation processes at the provincial level are suboptimal for euphemistically, with budget allocations in recent years, at least in the last 10 years, being more informed by historical spending, the spending from the previous year, rather than emerging health needs. So in a lot of ways, new things like NCDs are not fully funded. We have a set of ambitious reform proposals that look to consolidate these public sector financing streams, and also look at ways that we can improve the technical resource allocation process, as it's really based on devolving funding to the district level, which allows for better agility to local context issues. We also have obviously a difficult system where we have a two-tiered health system with a private sector and a public sector, with a lot of the capacity sort of concentrated in the public sector, because private sector, because that's where the money is. But what the reforms does present is a mechanism to contract in capacity from the private sector to augment any improvements that we're doing at a public sector level. Human resources, we can't talk about healthcare without human resources. 80% of health is a very human resource intensive thing. And on an aggregate level, when we count everybody, we compare quite well with our peers in terms of population to healthcare worker coverage. But when we start looking at lower levels of care or provinces and districts like our country is organized, there's a strong maldistribution where a lot of capacity is concentrated in our hospitals, both in the public sector and in the private sector, which means that as funding has been declining over time, our capacity at the primary healthcare level has been sort of, how can I say, muted. We're very undercapacitated at the front line. We have a strong training platform with 3 or 4 medical universities, but our limited fiscal space means that of every 10 graduates, we only absorb 3 into the public sector. I think one of the things that we'd like to look at going forward is really investments in primary healthcare, because we believe that it's a quick measure to sort of be responsive to emerging disease trends, and also allow an opportunity to better respond to the healthcare needs as they present in the communities. Our we have a very strong district health information service, but we obviously everything is really as good as the people that manage it. And while we do quite well in collecting a lot of the data, I think when it comes to the data analysis and evaluation, there's an area where we may need to invest a little bit more. If we look at diabetes, we know we have no routine data available on the management of diabetes. This is despite it being the third leading cause of death. At the moment, we only have modeled estimates, which puts the prevalence at around 10% of the adult population. So we're probably looking at about 4.5 million people living with diabetes, with only 1.2 million of them currently on treatment. We've got significant investments in communicable diseases like HIV and TB, but the data sets still remain complete, particularly around linking people who test positive for HIV or TB with the treatment that they need. When it looks to TB cure rates, we report quite high cure rates, but again, we have that access challenges with a lot of studies suggesting that up to 50% of people who present with known TB symptoms being pushed over onto a test. So that linkages with care is problematic and is one of the areas that we would like to focus on as we build back better. We need significant investments, as I indicated earlier, just to optimize our interpretation of facility level data and start working actively on improving health system responsiveness to the data as it emerges. COVID in South Africa, to date, we've got about 765,000 cases. Officially, we've had around 20,000 or 20 to 21,000 deaths. But one of our leading health agencies, the Medical Research Council, is also tracking excess deaths. And when we take excess deaths into consideration, we're probably closer to a mortality rate of around 50,000 people. This is partly because official COVID deaths are only those that have had a COVID diagnosis. Based on early implementation research, we're finding that more than half of official COVID deaths had at least one comorbidity. Hypertension and uncontrolled diabetes are the leading comorbidities, with more than half of the deaths associated with either one. Uncontrolled diabetes is a leading comorbidity amongst men, while hypertension is the highest amongst women. New evidence is continuing to emerge, but the role of increased risks associated with NCDs, particularly diet-related NCDs, is as clear as day. And I'm sure that story will unfold a little bit better as we try and understand this pandemic a year or two from now, looking back. The unintended consequences, we had a very long and severe lockdown that sort of really cramped economic activity. We were already in a recession prior to COVID, and I think it's been weakened significantly. Our most recent data suggests that we have a $30 billion US dollar revenue shortfall this year, with growth likely to only get back to pre-pandemic levels in 3 or 4 years, and that was already weak. This is really a problem in an environment where healthcare services to 80% of the population are almost wholly dependent on public funding. So we are worried that there could be some severe regression in access to health. Primary healthcare utilization over the years, we started off with a high in 1994 of around 3.5 visits per year. At the moment, that is really reduced down to less than 2 visits per year. And some of the significant challenges has been significant drops in HIV testing, which is the main pathway to accessing treatment. TB testing and immunization services have also been negatively affected. Increased perception of risk amongst those with the resources to have private medical insurance is likely to result in pricing in private sector going up significantly, having a negative effect on the public sector's ability to buy in healthcare services. Some of the other challenges that we've had is, and I think this is particularly topical in South Africa, is COVID-related procurement with large reports of corruptions. Luckily, there's been some arrests, but has sort of contributed to further weakening trust in the government. From the pandemic response, again, I've indicated that we had a national lockdown. The initial intent was around 21 days. It ended up being around 6 months. We had mass testing campaigns, initially limited by our ability to process tests, but that has significantly improved from 10 days at the beginning of the pandemic to less than 2 days in the public sector at the moment. We had strong public messaging around biomedical interventions across all platforms, including cell phones and the like. But as from a RAP point of view, I think what we tried to do was really just increase our messaging around some of the comorbidities and raising awareness around diabetes, and also using the opportunity to sort of frame the relationship of food and health and how poor food policy contributes to poor health outcomes, so that we could use that message to just raise awareness amongst those who may be living with diabetes around the increased risks. We also used our positionality as a leading public health advocate to support increased awareness in communities by running webinars, radio campaigns, and writing editorials in a number of the country's uh, public publications. As we build better, we think that the emergence of the pandemic has really exposed existing weaknesses in community health strategies. We think that to mitigate the sharp decline in primary healthcare utilization, we can use things like mass testing campaigns that includes testing for things like diabetes and hypertension. Because part of that is that better knowledge of the impact of these diseases will help us to advocate for other policies that mitigate them. We're looking at supporting greater linkages in cares and improve prevention messaging, where we are advocating for expanding the scope of the country's community health workers to include screening for non-communicable diseases. We currently have around 54,000 community health workers working primarily on HIV, but we think adding this addition of NCD screening can really just improve the efficacy of that cadre, as well as working on improving linkages between outreach teams and primary healthcare facilities. On the commercial determinants of health, we're really looking at getting industry to sort of play a bigger part in contributing to the response. We introduced a health promotion levy in 2018, which is initially targeted at sugar-sweetened beverages. And we've already managed in its first year to raise at least like 500 million USD in new funding. And I think part of our advocacy plans going forward is looking at how we can utilize that funding to support stronger health promotion messaging. But in addition to that, we are starting a campaign to support greater consumer choice and awareness by the introduction of front of pack warning labels. For us, this is as a twofold opportunity. In the first instance, it obviously allows us to label food that's particularly harmful to you, while at the same time also creating an opportunity for new categories of products to be added to the health promotion levy, so we can expand it beyond just sugary sweetened beverages. And I think our near-term target is to look at fruit juices, which masquerade as healthy drinks, but also contain considerable amounts of sugar. And I think finally, from our finance advocacy, we're looking at obviously increased investment in primary healthcare as we look to build back better, deal with the consequences of increasingly reduced fiscal space, because primary healthcare has proven to be much more cost-effective, as well as an opportunity to expanding health access to broader part of the population. And I think an important closing point for us there is that health is not just about healthcare. Health is a social construct. And I think part of engaging our communities more directly allows us all to start framing health as a foundation to achieving our broader human rights of human development and being able to direct the direction of our own lives rather than just being victims to the determinants that fall outside of our context. Thank you very much for this opportunity to share some of the work that we do, and I look forward to your questions. Thank you.
Thank you Thank you so much, Russell, for that incredible and comprehensive presentation. And that's a wonderful segue into our next panelist, Philomena Santa Ana, who is an incredible advocate for universal health coverage, especially using tobacco taxation. He is the coordinator of Action for Economic Reforms, and he writes a column for the Philippine business paper, Business World. AER is a policy advocacy organization that is at the forefront of the Philippine civil society response to contain COVID-19. So I really want to turn to Filomena to talk about, how Philippines is adapting to COVID-19 and continuing to sort of prioritize universal health coverage. Filomena?
Thank you, Vandana. I would like to share my PowerPoint. I hope it already appears on the screen. Does it?
Yes, absolutely. But if you could just move to the first slide, if you could just do from beginning, I think you're in the middle of your
There you
presentation.
are.
Perfect. Thank you.
Thank you to Vandana. Thank you for the introduction. My presentation will focus on the absolute importance of universal health care, or UHC, in responding to COVID and in preparing for the better new normal. And the challenge there is how we can sustain the financing for UHC, and that will necessarily entail tax reforms. But for some context, I present the Philippine situation as of 22 November 2020, and I won't go into the details of these uh, numbers. The situation is no different from other emerging markets like South Africa, India, etc. The Philippines is not among the top 20 in terms of fatalities or number of cases, but the problem is that since the outbreak of COVID 19, the pandemic curve or the epic curve has not really been flattened. And the current trend shows a reduction of cases, but the cases remain high in absolute terms. And as this slide will show, we have active cases of about 24,000 people. And so the challenge remains how we should flatten the curve. The crisis, it's a multidimensional crisis. It's a health crisis, it's an economic crisis, and as you are aware of, the Philippines has also been subject to a series of super typhoons. Despite all these crises, we should look at the opportunities to transform Philippine society and, in fact, transform the whole world. So our motto is never waste a crisis. And in this context, we see the absolute importance of universal health care to flatten the curve as well as to prepare for the post-pandemic situation. We have a law on universal health care, and this was passed just before the outbreak of COVID 19. So it's not yet fully in place, and the unpreparedness of having universal health care has contributed to the slow and inefficient response of the Philippines. Nevertheless, COVID 19 has compelled government to accelerate the setting up and implementation of universal health care. For example, there is a need for electronic medical records, there's a need to strengthen local initiatives, and these reforms are now taking place precisely because government has no choice but do these reforms. The question, however, is how we can finance universal health care, particularly primary care, in a sustainable way. In a sustainable way, for health insurance, those earning incomes mainly coming from the formal sector make the premium contributions based on the principle of ability to pay. But then the majority of the Filipino people belong to the informal sector. So for the poor and indigent members, government has to subsidize membership in health insurance. And the subsidy comes mainly from taxes, in particular, sin taxes. One lesson we can learn from the Philippines is the increase in sin taxes, specifically on tobacco and alcohol, over a period of time, and these taxes have been earmarked for health, specifically for universal health care. So these sin taxes have subsidized the health insurance for the poor and vulnerable groups. But because of COVID-19 and the resulting deep recession, the expenses, example, for health and health insurance, but not only for health, but also for social protection, food security, job preservation, etc. These expenses have skyrocketed. On the other hand, revenues have plunged because of the disruption in economic activities. The decline in economic activities, together with the high employment, high unemployment, have resulted in the fall of health revenues, including the premium contributions as well as the revenues from sin taxes. So there is an imperative to generate the revenues. But since taxes are declining at this time, the only way to provide financing to flatten the curve and to provide social protection is through higher deficit spending and the economic stimulus. Nevertheless, despite the stimulus spending of the government, it is now spending around more than 9% of GDP for to finance the stimulus. The, the spending for universal health care is inadequate. The financing for primary care remains very constrained. Just to illustrate, the human resource for health budget is lower by 14% compared to 2020 budget. I'm talking here about the budget for next year. And it's very ironic that the budget for human resources, which is a component, a key component to fight COVID, has even decreased. It's much lower than what the Department of Health is asking for 2021. And because of this, there's even going to be a reduction of personnel, particularly positions for nurses. Another example is the slashing of the health promotion program by 15%. Although the Department of Health requested a significant increase in the budget for health promotion. Health promotion is associated with with both the medical and non-medical interventions that are necessary to prevent the spike in COVID-19 infection. The inadequacy is also manifested in the funding for the COVID-19 vaccination. There is some money, but the amount that has been proposed for the 2021 budget will only be good to vaccinate the frontliners and the poor elderly. And definitely, this is far from the number needed for immunity. Another critical component is the health technology assessment and the electronic information systems, all necessary for effective function of UHC. These programs are underfunded. That's why we are stressing the importance of financing. And this is where the sin taxes become very, very relevant. We have a very powerful argument for an increase in sin taxes. We do not even have to wait next year or after after we have that stimulus to put in place taxes. Sin taxes can even be done at the soonest. And we have the experience to show that. And here are arguments, and you are already aware of such arguments, that cigarette and alcohol taxes are health taxes. They discourage consumption, and they reduce the economic burden. The burden is very, very steep. And just by discouraging consumption, even if you don't get the revenues, this will already address a big part of the health problems we are facing. Then politically, these taxes are popular taxes. They have the support of the people. And third, they really will bring in revenues because the demand for tobacco, the demand for alcohol are considered inelastic, which means that even if prices increase, the demand will remain. There can be a moderate reduction of the demand, but this will be compensated by the much higher revenues. So this will assure the sustained flow of revenues, even if taxes are increased. The next slides will show the advantage of increasing sin taxes. And my example here will be focused on tobacco. So from 2012, we have had a series of tax rate increases for tobacco. This slide shows the increase since the series of increases since 2012. The next slide shows the increase in the revenue collection. So before 2012 and up to 2019, again, you can see the continuing increase in revenues. And the next slide is about the increase in the health budget arising from the increase in sin taxes, specifically taxes on tobacco and alcohol. And from 2012 till 2017, that's the latest figures I have here, one can note the significant increase. And of course, as I said, a high tax on tobacco leads to a reduction in consumption, and we see declining smoking prevalence. So here the curve will show that from a high of about 32%, it has decreased to 23.3%, and the latest we have, although it's still unofficial, is that the prevalence rate has gone down to 18%. And the major factor behind that is the increase in tobacco taxes. So sin taxes will contribute to the better new normal. It's not just that it will help in our fight to flatten the curve, but more importantly, this will create the conditions for a better new normal. We'll be able to expand and consolidate universal healthcare in the post-pandemic period, given the huge financing that it requires. At the same time, as I said, we are doing stimulus right now, but that stimulus has to be unwinded, which will mean a gradual reduction of the spending deficit. And in this context, new taxes are necessary, and sin taxes, therefore, should be one of the drivers for new taxes for health and for the economic recovery. Thank you very much.
Thank you, Men, for that incredible presentation. And that was music to my ears as a global tobacco control advocate myself, about how sin taxes, especially on tobacco, can both strengthen health systems and universal health coverage. So from creating health access and equity in South Africa and universal health coverage in the Philippines, we move to our third and final presenter, who's going to talk about strengthening hypertension delivery in India. Om Prakash Bera leads the cardiovascular health work for the Global Health Advocacy Incubator based in India. And he's going to share about how, even during these difficult times, hypertension systems have been strengthened. Om, over to you.
Thank you so much, Vandana, and all my colleagues. So I am presenting to you a case study from India, which is a part of the global project, which is being implemented in one of the province, Punjab, and it's one of the states in India. So in India, going back from 1990 to 2016, there has been a movement from communicable disease to non-communicable disease. And as you can see, like most of the states in India have like moved away from diseases like tuberculosis and chikungunya, malaria, dengue, to more non-communicable diseases like cardiac diseases, metabolic diseases, and so is the situation across the country. So this study has been quoted from like India Health of Nation States 2017. And according to the recent Global Burden of Disease report, hypertension now is the biggest risk factor, and high systolic blood pressure contributes the maximum amount of like the disease burden right now, and across the globe and across India. So according to the district level health survey, which is a nationally represented survey, so the prevalence of hypertension in India, it varies from around 23% to 41%, and in some of the states there has been a high prevalence of hypertension, like the state of Punjab, which has a prevalence of 41% in men and a prevalence of 25.4% in female, and an overall prevalence of 35.7%, clubbing it to pushing it to the topmost ranked state in terms of prevalence. And that was the focus of why we started working in Punjab. And hypertension is overall related to 50% or 51% of all the stroke deaths, as well as 45% of the coronary heart diseases deaths in India. So this is the Delhi data. And across the globe, we have seen reports that hypertension is taken lightly, and most important thing is hypertension is not controlled. So giving a very specific reference to India, there is a less than 11% of population do have hypertension under control. And as you are all aware that uncontrolled hypertension leads to a battery of diseases which can affect multiple systems. So then Global Health Advocacy Incubator, in collaboration with Government of Punjab and local grantee PGIMR, they formulated a project which aimed at strengthening political, administrative and programmatic implementation of the hypertension services by the Government of Punjab. It also focused on generating media support, because that was the connect in which population can be sensitized across the health impacts, across the epidemiology, and on the patient treatment and the compliance and the control. And there was a component of strengthening primary and community health services, because in public health or in across all the health systems, if community is not a part of your umbrella planning, then the no program is going to be achieve success. And during COVID-19 period, we devised a new intervention of strengthening the telemedicine services. So as we move on, since December 1st of December 2019, we actually launched the project, and in the early periods till March 23, 2019 and 2020, we actually formulated a NCD steering committee, which comprised of experts from program management, from academia, from civil society. And we advocated for increased public budgetary allocation for NCD care of population, which includes screening, detection, management of hypertension and diabetes mellitus. And we advocated for operationalization of health and wellness centers. So this is the community health center, and this is the first point of contact between between population and the medical staff. And we also established and operationalized the telemedicine unit at remote health and wellness centers, and created a central hub for provisioning of uninterrupted services during COVID-19. So there was also establishment of a cardiovascular resource center. You can visit it, www.rccvs.org. The aim of this establishment of this resource center is to bring in all the evidences, all the materials, all to a single platform, so that researchers, policymakers can actually go through it, and that can help in policy planning and designing. Till from December 2019 till date, there has been more than 50 media articles, blogs, op-eds on hypertension, diabetes, telemedicine, and primary health. So we were progressing very smoothly till March, when on March 23, India moved on to a complete lockdown phase, and from since March till now, we have been in a partial lockdown state. So because COVID struck down, so there has been multiple problems, but I have thematically put down it across five important points. So one is the declining access, because COVID-19 struck, so there were physical restrictions, and due to physical restrictions, patients usually found it difficult to get access to health facilities. There was also a priority shift. Governments usually have shifted the priority from regular national health programs to controlling COVID. And that's how the entire staff, human resource, they have been moved for COVID priority duties. There have been complications due to COVID and NCDs, and that is not like a hidden fact right now. We all know that like comorbidities have made prognosis of COVID and recovery of COVID patients much harder. There were increased cost of transportation, medicine services, and that all added up to the cost out-of-pocket expenditure. And there has been like ultimate confusion among the what should be about like the medical advices related to COVID and by the comorbid patients. So these were the important problems for because we were there to help the government, and we were envisioning this type of problems. We realigned the project, and we concentrated all our efforts on three important aspects. One was telemedicine, second was online capacity building, and the third was the bi-directional COVID NCD community screening and communication outreach. So all these three major interventions, they actually helped us realign the project objectives, and we actually connected with the population once again. And uh, uh, I would say like the entire telemedicine model was built on a hub and spoke model, in which there were like spokes, remotely controlled spokes, and there was a hub in which like doctors were sitting and providing medical advices, and that actually helped down like to 12 million rural beneficiaries actually benefited from this type of a model. And with this type of a model being demonstrated in Punjab, Punjab became one of the states and to achieve the topmost rank in case of healthcare provisioning and by the central government. And in this slide, I would how the Chief Minister of Punjab actually tweeted this in the domain. And the summary I would like to bring on like 5 important points. Like COVID-19 has already created immense pressure on the healthcare system of like all the mighty countries as well as like the LMICs. But at the same time, it has provided us with an opportunity to build strong healthcare systems to future-proof it against any potential pandemic. Telemedicine has emerged as a cost-effective tool and is here to gain further. And bi-directional population-based screening can improve case detection as well as fatality, and targeted BCC campaigns through proper channels can deliver messages to the population. So these were some of the key summaries and takeaways from this case study report from India, which can be adopted worldwide. And so that's it from my side. And thank you. And thank you so much, Vandana and team, for giving me an opportunity.
So thank you, Om, for that incredible presentation. I think all three were really comprehensive, sort of looking at all three different aspects of healthcare. The financing of healthcare, the overall access to services, and especially addressing social inequities, and then a specific NCD and the treatment. I'd like to sort of end the panel with sort of a question. It's sort of a two-part question for all of you. One is, each of you have sort of gained momentum for your issue. What do you see the challenges in keeping up that momentum that COVID has provided for your issue? And did you come up with any unexpected partnerships? So if you could kind of keep your answer to sort of a minute each, I'm going to start with Russell and then Men and that Om. Sort of how do you keep up the momentum and the unexpected partnership? Russell, if you want to go first.
Yeah, look, I think our partnerships have expanded. We've started talking to non-traditional health actors and really just broader community engagement from people working in education, people working in public finance more broadly, and also just like looking at how we can really just sort of reinvent some of the things that we've been doing already. So I think that momentum will take us forward. Obviously, there's a lot of contestation. I think the last 10 years around global health, there's been a lot of exceptionalism. And I think now it's an opportunity to consolidate. So I think for us, that's the big unintended benefit, as well as stronger linkages with research partners. In terms of maintaining the momentum, primary healthcare, I think, is an easy sell, right? Especially in an environment when fiscal space narrows. But in investing in primary health, I think the main thing for us is to push hard on screening and testing, right? Particularly when it comes to non-communicable diseases. Our current evidence base is very narrow. Most of the stuff is modeled. And our view as an organization is that if we can get more people to understand the public health threat, presented by NCDs, we can make a stronger case for the kind of policy type initiatives that can support it, particularly front to pack labeling when it comes to diet related NCDs, as well as using that revenue raising model from the health promotion levy to fund primary prevention. And I think for us, this is the huge once in a lifetime opportunity to really just change the focus of the health system just from curative issues, look at consolidating community health programs by making linking NCDs with communicable diseases. And I think the path is clear, the opportunities are immense, but I think there's a lot of work that's needed over the next 3 to 5 years. But I think what the crisis has done, and I think what Min has also said, is a real opportunity to change the narrative and to change the debate and make sure that access to health and health enablement and literacy is everyone's business. We saw now what happens when you neglect health. We had a global financial, economic, and political crisis. And I think this, as activists, we would probably be remiss not to use this opportunity to build back better by focusing on the environments that we're working in and taking advantage of whatever opportunities there are. Thank you, Vandana.
Thank you so much, Russell. Men?
I wish to emphasize one challenge which is universal, a challenge that applies not only to my country, but a challenge for the rest of the world. And this is the challenge of a collective action. A collective action has to be sustained. We cannot relax, society cannot relax its guard despite the good news about the vaccine. Collective action still has to contend with building trust amid actions undertaken by authorities to politicize and commercialize the response to COVID 19. The good news, though, in doing collective action is that in the Philippine context, new networks or coalitions have emerged together with existing ones, like the syntax that you're familiar with, Bandana. And the emergence of new coalitions have made us effective for an all-round effort to fight the pandemic. Civil society response addressed both medical and non-medical interventions. So coalitions like COVID-19 Action Network, Health Professionals Alliance Against COVID-19, Move as One Coalition, which is for active transport, Better Broadband Alliance, which is for internet access for all, are tackling different major issues related to flattening the COVID-19 curve. And for the momentum, we have to recognize that infectious diseases are no longer a black swan. They have been occurring more frequently. At the same time, non-communicable diseases continue to rise among the poor and non-poor populations. The key, and this has been the message of our panel, is to have primary care, universal health care, anchored on sustainability, on equity, on efficiency. In this context, we in the Philippines, including my organization, are involved in the advocacy to mobilize resources for UHC, the recurring message in my presentation. And also in this slide, health taxes like taxes on cigarettes, alcohol, vaping play an important role. They not only provide funds for UHC, they likewise help reduce NCD or non-communicable diseases. Thanks.
Thank you so much, Men. Om?
Yeah, so I would not go through the challenges, but I am like looking for like a huge opportunity that COVID has provided for NCD program. In the last like few years, we have seen that like even though the proportion of NCD affected population has increased, and right now it is like more than 60% of the population is getting affected. But then also it didn't got like that attention. Neither there was like funding commitments. With COVID and with like scientific researchers coming in that like comorbidities like hypertension and diabetes have like made the COVID prognosis worse. So this clearly goes to the ears of the policymakers, making it a mandate of the government across, to highlight like universal screening, and most importantly, screening for hypertension, screening for diabetes mellitus, and that will go a long way. Going back by the learnings, by the scientific data that has gathered in this COVID wave, so none of the policymakers can actually risk for not giving the attention to NCDs. And going back to the second thoughts on the unexpected partnerships that have emerged, definitely I would say we have scored a goal on gaining new partnerships in which multiple partners, like-minded partners, have come together, have voted for the cause, and they have all become a consortium at the national, at the state level, for taking the NCD movement much further and to much heightened, to much greater heights. And that's how the policymakers are actually believing, and they're actually committing to the cause. So I see this is a great opportunity, but the main focus, we should be very focused with the key research, with the key takeaways that should be presented to the government, and at the same time presenting cases across the world, how the world actually converted this COVID pandemic into a an opportunity, and how this COVID NCD syndemic, as was the article by Dr. Richard Norton in the Lancet series, the syndemic actually gives us a big opportunity that we should try to maximize. Thank you.
Thank you so much to our incredible panel. And so for me, in summing up, there's sort of, three key themes that emerge out of these topics that are all interconnected. One is we've got to, I think the crisis showed us we've got to strengthen the primary healthcare systems. We're looking at three completely different countries in South Africa, India, and Philippines. We've got to, really focus on the primary healthcare system. We've got to really focus on universal screening for NCDs, which have to be prioritized, because as the pandemic is showing up, all of these undiagnosed, untreated cases of hypertension and diabetes are the ones that are most adversely affected when the pandemic is hit. And thirdly, I want to really emphasize is that, we can look at syntaxes for both strengthening the primary healthcare system and for moving towards universal health coverage, which is a goal for all of our countries. So with that, a big thank you to the panel, and I hope that the learnings that we have all shared collectively will sort of strengthen this movement globally. Thank you.